Thank you all for joining us, and I appreciate the opportunity to share some information and get the word out there about this vulnerable population and some of the things that we might be able to do along the way to get some treatment for this significant issue in the United States as well as the world, and especially in our little area of Kentucky. So we're going to talk kind of an overview of addiction. We're going to touch on a lot of different stuff. When I show you the agenda, you're going to go, oh my goodness. And I'm going to say, well, we're all overachievers, so we can get this done. But yes, I'm Dr. Cheryl McClain. I'm the state medical director for Brightview, and double board certified in family medicine. Did that for 20 years. Went into leadership, fell in love with this population in 2016 when I met this population in Eastern Kentucky and decided to get my addiction degree. And here I am teaching and educating. So appreciate that opportunity. I have no disclosures, no financial disclosures. So we'll move right on. The objectives, we always have to have objectives when we do something like this. So we're going to identify the goals of medication-assisted treatment. We're going to look at understanding and at least one comorbid condition that's associated with substance use disorders. And then finally, we're going to look at integration of MAT, the buprenorphine induction, and how that can be beneficial. And we're going to talk about that a little bit, particularly with the emergency department. And hopefully we're going to have some emergency physicians here in this population or listening to it or watching it later. So looking forward to that. So here's that agenda that I mentioned. And as you can see, it's quite long. We're going to touch on a little bit of everything. That's why we're going around the world. We're going to do that in 60 minutes, hopefully. Sometimes I talk really, really fast. So out there in the audience, if anybody wants to raise their hand and say, hey, slow down, you can do that. But meanwhile, let's look at the agenda real quick. So review the drug crisis in the world, and then the US, and then finally Kentucky. So we're going to touch on that, some data. We're going to look at addiction, what the diagnosis is, substance use disorders. We're going to look at the comorbidities around that. Very important to understand that and understand that that's part of treating this population. We're going to look at prevalent SUDs. We're going to mention those and kind of what I see in my practice in the state of Kentucky as we go around. We're going to look at potentiators and cocktails. I like to mention that because if you're not in this world and you happen to look at a urine toxicology and you see some odd things in there, you might go, oh, that reminds me, someone mentioned that somewhere that this could be an issue. And so I think knowing that and seeing that and recognizing that is very, very important. We're going to look at two substances on the street, the new kids on the block. And the treatment goals surrounding MAT, looking at the barriers, which is huge. They are huge. The treatment options, and then the goals. Why do we do it? What's the driving force there? Regulations and compliance. We all love that, right? We're not going to spend a lot of time on that, but I'm just going to show you kind of what you need to know, maybe some links there so you can go study it late at night when you don't have anything else to do. And then finally, the brief review of perioperative management of bupe patients. That comes up a lot. There's some different schools of thought. There's some changes in that. So I'm just going to briefly touch on that. And then explain the benefits again of that integration of MAT and why that's important, particularly in the emergency room. And then the why, kind of bring it all together. So yeah, let's get going. So the world drug crisis. If you can look up here and see the questions here. So we're going to look at these, the most widely used illegal drug in the world is, and you've got some choices there, cocaine, cannabis, amphetamines, opium. So, take down, what you think that is, just for fun. If we had one of those little clickers, I'd be asking you to do that. But instead, just, kind of take a peek there and write down what you think that is. Worldwide, approximately what percentage of the world's population, ages 15 to 64, reports at least one illicit drug use, using at least one illicit drug use in the previous year? Less than 1%, 4 to 7%, 20 to 32%, or over 45%. Alcohol is least likely to be consumed in the United States, Europe, North Africa, or Australia. Great Britain historically used a medical model of drug use or zero tolerance policy or supply reduction strategy toward drugs or war on drugs approach. Which of the following drugs legally available in the United States in the 1800s and early 1900s, and maybe a hint here, started all some of the problems that we're going to be talking about. So as we go through there, just while you're thinking about those answers, a couple of fun facts. So there's 5 top countries in the world: Afghanistan, Iran, Russia, Great Britain, and the United States that kind of top the 5. So a little fact about each of one, though. So let's talk about Afghanistan. Afghanistan is the number 1 producer of opium and formulates that into heroin and other products. So a big deal there. 1 million people in Afghanistan are in the addiction throes out of 36 million. Looking at Iran, Iran has the highest rate of addiction per percentage, and Russia is looking at increased IV drug use. So looking back at Iran, something interesting about Iran is due to the Islamic population there, they do not have any tolerance to drug use, and they actually use the death penalty in even non-violent crimes associated with drug use. So quite harsh there. Russia, I mentioned, has the highest IV. They're having more difficulty with IV drug use, and also they do not participate in any harm reduction model. The United States, although we don't produce much, we are the highest users. So we are number 1 at something. And then Great Britain doesn't have a huge issue with opioids and opioid use disorder. Their main use is marijuana, followed by amphetamines and cocaine. So just a little trivia there when you're doing some of the trivia at some of the local resting stops. Alrighty, let's get to our answers. So question 1, the mostly used illegal drug in the world is cannabis. Have to say I see that in many of the patients that I treat in the addiction world. It seems to be, I'd go hand in hand, certainly, with this population, as does tobacco. And we're going to talk about some of those prevalence a little bit later. Worldwide, approximately 4 to 7% of that age group have reported using illicit substances in the last year. Alcohol, I'm sure no one picked A there, the United States, but it's least likely in North Africa to be consumed. Great Britain historically used a medical model of drug use as opposed to a criminalization or penalty punitive, as some of those world countries I mentioned earlier. So which of the following drugs legally available in the 1800s and 1900s? Opium. All right, let's look at death rate per 100 population. And if you, this is world drug overdose crisis. Sorry, it's in white there. It should be in black to the left there. But looking, and I know that that's hard to see, but what I wanted to point out here is on the left side there is the United States. We, again, top that. We're the top users and the top country with overdose death rates, followed by Canada, Australia, Libya, Nigeria. And then on the right side, we're looking at the lowest countries. So you can see there, Venezuela's at the top of that and on down. Italy's third, Uruguay, Panama, on down there. So those are the least likely to have the overdose there. Yeah. You have to comment on that on the right. Why that is the lowest? We have any hypothesis why they're lower? What I could have done when I was looking at that, and the question here was, do I have a hypothesis on why those areas are low? But I wonder, some of the happy areas, the least amount of use of illicit drugs, would that correlate? That's a fascinating question, and I don't have a good answer for you. I would also venture to say that supply and demand probably is more difficult in that area, in some of those areas as well. But great question. All righty, moving on. So the United States, looking at the United States drug overdose crisis. So this was released in 2023. Data is always a couple years behind, unfortunately. So this looks at the late 1990, 1999 to 2021. So looking at that, what I want to get home here is it's increasing for sure over the years, and that top, the blue is total, the columns are total numbers, and then the yellow line at the top is male, and then the bottom line is female. So the males are higher numbers in overdose in the United States than the females. Going on, looking at the numbers, over 100,000 overdose deaths of all drugs, and the year prior, over the same time frame, it was 78. So this was something that during the COVID era, fentanyl era, and these are certainly contributors to that. That does show a 28% increase over that year. So we're looking at involving opioids only in this situation. You can see the graph looks very, very similar. The males are on the top again, the females, gradually going up as well, but over the years certainly increased, and totaled at 80,000 in 2021. Remember, about 100,000 were total all overdoses. So a significant portion of those are related to opioids. Looking at Kentucky, this is a great report. It breaks it down into counties. If you want to go look at that, see where your county comes up. Jefferson County is number one. Actually, Barron County, which is here, did I get that right? Yeah, awesome. Is actually fairly low. So you guys are doing a pretty good job here. It was around 11 versus the Jefferson County, which is Louisville area, where I grew up, was over 200. So you can see the difference there. Certainly the population's higher in the city there, but than you guys have. But looking at this fatality report is helpful. You can go to that. There'll be a link there when you look at these PowerPoint or the PDF. But some numbers from that. So looking at that, in 2019, 1,300 overdose deaths. The next year went to nearly 2,000. The next year, 2,250. So looking at that increase of 49% from 2019 to 2020. And again, we think a big part of that was COVID, the isolation, the use, the lack of involvement and care. There was the 14.5% increase from 2020 to 2021, so not as great, but still increasing there. As mentioned there, the contributors, the fentanyl and COVID, the two big ones. 90% of all those overdose deaths did involve opioids, and most of those, 70% plus, involved the fentanyl. So looking at that in a graph form, you can see the increase there, the 49%, and then the 14.5. So why does this happen? What's kind of the basis of this in some ways? I'd like to show this slide and this graphic, because when you look at this, what's the big deal about fentanyl? Why carfentanil? What are they? What's the big deal? Why don't people know? Well, they look the same. They're white crystals. The amount of heroin that can result in overdose, you see that there. Then you look at the few specks of fentanyl, and then you take on the carfentanil, the elephant tranquilizer, or known as that. When I was in Eastern Kentucky, I want to say it was 2018. There was like 17 overdoses in one day, and many of those deaths, and it was contributed to a bad um, uh, batch of illicit heroin, fentanyl, which had carfentanil. Even some of the first responders had some issues with that. You know, what also is interesting as we go through here, and I think of some of my patients and some case scenarios, what I find really interesting is when someone hears, you know, this is intuitive that we would run, but when someone hears that someone overdosed and that dealer has good stuff, they go get that. You know, that's the addiction brain working. You know, it's not sensical. It makes no sense. We would again all run from that, but they sometimes seek that dealer out. Also, I can tell a story about a patient that I took in that he was in maybe late 30s, early 40s. He'd been corporate. He had a six-figure income. He had a car, a home. When I met him, he was homeless, no money. I always ask how many times, you know, have you overdosed? How many times? 40 plus times. Again, you know, this is a smart guy. This is a guy that, you know, is has a lot of education and was very successful. And he continues to use despite having overdosed 40 times plus. So I'd like to show that, just to show this graphic on why it happens. You know, a lot of times folks think that they're getting heroin, and in fact they're getting fentanyl, and they'll use the same amount as they did, and that's kind of the lead way into so many overdoses, particularly if it's laced with carfentanil. We're not seeing that. I'm not seeing carfentanil recently, thank goodness. Mostly what we're seeing here is fentanyl. And now that folks know that it's generally 100% fentanyl, that they can decrease the use or know what they're tolerant to, and that sort of thing. So a little bit more eye-opening when they go into that. But in the past, before you know, that happened, they didn't know what they were getting. Addiction. So how does ASAM define that? I love this, and I think it's the meat and the potatoes. A treatable chronic medical disease involving complex interactions among the brain circuits. So genetics, epigenetics, the environment, and the individual's life experiences all take a toll there. So genetics are about 50%. Epigenetics, a very interesting topic. That's the expression of genes based on experiences and that sort of thing. So you can see how that their life experiences can intervene there. A story about a patient who I did an intake on, and again, I always ask, you know, what was your first age at use, and what did you use? This gentleman said he was 5 years old. His parents threw him out of the house, gave him a joint, gave him his little toys, and said, go play. And so that's what he did during the day. He would get his marijuana from his parents, and he'd take his toys, and he'd go in the woods and play. So, you know, many of us, I certainly was sheltered from that growing up. And I think it's hard for us to know what these folks go through. And sometimes this population can trigger some of those feelings in us of, well, they can stop, or this or that. Well, really, they can't. They can't. We can help rewire those brain circuits, and we can help keep them safe while we're giving them the other tools, which we'll talk about. But they don't make a choice to do this. All these things are environmental. I can tell another story. I can tell stories all day. Maybe I'll get to that one later. 10 most common signs: intense cravings, tolerance, withdrawal symptoms, physiological dependence, certainly. Engaging in risky behaviors. They have to get the money to keep from getting sick. So that's what happens after they've been doing this for a while. They no longer do it to get high. Yeah, some people do for sure. But many of these patients in this population find the drugs to keep from getting sick. And that's very, very important. They'll engage in many, many risky behaviors, including stealing, robbing, promiscuity with prostitution, that sort of thing. So drug-seeking behaviors, neglecting responsibilities. Looking at the behaviors, and the behaviors are very important to know because physiological dependence does not equal addiction. So when we've got all of our different hats on, and you're treating a pain patient, and they've got some physiological dependence, right? But they're not exhibiting any addictive behaviors. They are not addicted to that drug. They're physiological dependent. So I'd like to get that point across. The behaviors that you're looking for, or that you're going to see in this population for sure. The isolating behaviors, lying, manipulation, and engaging in criminal acts. Many, probably 50% of my patients, of course, I have high acuity patients, but many of them are incarcerated and coming out or have that history. Shifting the blame. I can tell you, I could write a book on all the excuses for losing their drug, missing their appointment. It's amazing the accountability or lack of it in this population. So that's one of the things that we work on when we're treating the whole person, helping develop that accountability and what that means. Certainly, we see abusive relationships. Either they're the perpetrator or they're on the receiving end. See that a lot, and that's very disheartening at times. But certainly, we can offer services to those patients and help. So, addiction equals what happens. Why do we care? With this population. Well, the big thing, family and relationships. Community despair. So this affects everyone. Everyone is touched by this. You probably know someone who either is currently addicted to a substance, or maybe has overdosed and passed, or a family member, or it could be a colleague, it could be a neighbor, it could be your son, it could be your daughter, it could be your spouse. Financial losses, and the time spent trying to find the substance, the time spent in consuming the substance is incredible. That's all they think about during the day. So the responsibility and the accountability and those things, neglecting roles, neglecting so many different things, is kind of the way, the life in this world. We also see a significant increase in HIV, Hep C. Certainly, I see that. Certainly, I see increase in infectious diseases, and I know you guys have seen that as well in your line of work. In the hospital, hospitalist, ER, ICU, that sort of thing. We see that. High risk for incarceration, other legal issues we talked about, and the final there is the increase in foster parenting. One study I saw was an increase in 25%. I wouldn't be surprised if it's higher in this population. It's amazing the number of patients who come in who have children and the grandparents are raising them, their parents are raising them, or they're in foster care. And one of the joys that I have treating this population is when the motivation is for that patient to get back their children, and the joy of that when that happens, and it does happen. So what are the comorbidities associated with substance use disorders, and why does it matter? Well, when you're treating that patient, you have to wrap your arms around the whole patient. You have to look at everything about that. If they've got a comorbidity, whether it be medical or psychiatric, and we're going to run through those, if we don't pay attention to those and get them help in some fashion, then their recovery chances are diminished. So we want to help whatever we can do to keep them on that positive road of recovery. And so whatever we can do and recognize and get them the help is ideally what we want to do. So looking at the medical, the big things, endocarditis, IV drug use in particularly affects the tricuspid valve and the right side. So in less than 10% of non-IV drug users, this is affected. So that could tip you off if you're looking at that and see that. GI related. So we've got certainly the Hep A, which isn't a huge issue. I don't see that often. Hep B, I see that some. Hep C, incredible number of Hep C patients. There's some studies that show one person with Hep C will infect 20 people. So we've got to treat those. I know years gone by that if that patient was continuing to use, they were not candidates to be treated. We've got two great combination drugs that treat this Hep C in the 95% plus success rates. It's easily treated. Now in the state of Kentucky, anyone can treat it. And there's something called the simplified protocol. I have a passion for that. If you're interested in that, just get with me, and I can put you on the right track there. But very easy to treat, and high rate of success. And sometimes these patients have been diagnosed with Hep C for 10 plus years, and they didn't know that they could get treatment if they were still using. And that's a form of harm reduction. Certainly, it's very expensive, and we ideally don't want them to go using again, but that is a positive factor in their recovering from Hep C, and that can help them stay in that pathway. Let's see, constipation, bloating, early satiety associated with any opioid. So that's not unusual to see the opioid-induced constipation for sure in the opioid use disorder. Some of the medical soft tissue, skin and soft tissue. So we've got cellulitis. We've all seen the cellulitis there from IV gone bad. And then the skin popping. Right there are scars, and there's evidence of that. So when you see that, typically in the lower extremities, you can see it in the upper extremities, but that can give you a hint that there's been some missed IV drug attempts there. And then finally, the necrotizing fasciitis right there. So very dangerous and very, very difficult to treat. The bone osteomyelitis, you can see that in the top x-ray there in the proximal tarsophalangeal, metatarsophalangeal joint there. And then the septic arthritis in that sternoclavicular joint. So those are some of the things that we can see. Interestingly, folks do use their jugular. They'll use mammary veins. They'll use anywhere, in between their toes and in between their fingers. Certainly, the antecubital region. But when you're looking for track marks or use, don't ignore some of those other areas. And patients who are professionals or in places where they want to not show that, they know where to go so that those can be hidden. So other things, the HIV, about 1 in 15 cases attributed to IV drug use in the United States. And certainly TB. We're seeing an increase in TB in our population, not active TB, but latent TB. And part of that is certainly associated with being in close quarters, incarceration, this population. But also we're seeing an increase across, you guys might be seeing this just across the population because of some of the influx, in particularly the Ukraine immigrants that are coming over. They have a high rate of latent TB. So 1 in 5, I believe, is kind of the going rate now of people around, not just Ukrainians, but or immigrants or incarcerated folks, but anyone. It can be that high for latent TB. So latent TB most of the time will lie dormant, is not symptomatic, but at any point could become symptomatic, and it's less than 10-20% of latent TB folks who become active, but it's something that we need to pay attention to. When you get that positive test, we use the quantiferin gold, quantiferin plus gold test as opposed to the PPD. But either way, if you get a positive test, it's very important to consider treatment in that population. One, for herd health, to protect us all in our communities. But we certainly see an increase in both of these in our patients. Psychiatric, what's the importance of this? The importance is if you don't treat the underlying mental health issue, the hopes of recovery diminishes tremendously. So again, by treating that whole person, looking at what they need, getting them the help, the community resources to that mental health provider, or treating yourself, because quite oftentimes we have trouble getting them to our appointments. So setting them up to see someone else sometimes is tough. So we will treat that, and I'm sure many of you feel comfortable treating certainly the first line anxiety, depression, and that sort of thing. But looking at that substance-induced mental disorders, methamphetamine psychosis, for example, generalized anxiety disorder, we see that tremendously in this population. I'm going to jump down to post-traumatic stress disorder, incredibly in this population. If that person's been incarcerated, highly likely to have that as well. Major depressive, for sure. Bipolar disorders, absolutely. And schizophrenia, that's one of the most difficult ones. Many of our homeless patients, schizophrenia, just difficult to treat, difficult to keep them housed, difficult to get their medicine, take their medicine, very difficult. Sleep disorders, cannabis tops that, methamphetamine, cocaine, the stimulants for sure. And then additional substance use disorders. So quite oftentimes we'll see concurrent multiple substance use disorders. Rarely will we see only an opioid use disorder or one methamphetamine. Yeah, we do see that, but generally we see concurrent. Probably the most likely is the opioid use disorder and then the methamphetamine. And that's in addition to tobacco and cannabis, which we'll touch on. So the prevalent SUDs that I see, certainly tobacco would be at the top. I should put cannabis second because we see that incredible amount. Opioids concurrently would be up there, and then the methamphetamine. So methamphetamine is one of the most difficult substance use disorders to treat because we don't have a good medication for that yet. We don't have a good tool for that yet. We do use several things off-label that sometimes can be helpful. Studies show that contingency management, if you don't know what that is, that's a reward system. So there are some apps that the patient can do, and they can spin a wheel, and then they can get a reward for that, or your office can do something of that nature. For example, if they've got a urine toxicology or a urine confirmation, that is appropriate. We try to stay away from clean and dirty, but is appropriate, or negative. Those are the two terms that we would use. Then maybe they get to pick something out of a box, and you'd be surprised at even adults at how important that is to them. So contingency management for stimulant use disorder, big time, and then behavioral therapy is big. Cognitive behavioral therapy. So we see alcohol for sure, and oftentimes we'll see alcohol isolated without other substance use disorder, with the exception of the tobacco and the cannabis. We oftentimes see that together, but we oftentimes see the alcohol without the meth or the opioid or the stimulants. And then under the sedatives, the benzodiazepine is becoming more and more problematic. We're seeing more and more of that, gabapentin. And I don't see much of the other sedatives at this time, really. Mostly it's the benzos and the gabapentin. Cannabis, yeah, we've already talked about that. So what's a potentiator, and why is that important? I kind of mentioned earlier, if you're looking at a urine confirmation, for example, and you're seeing dextromethorphan in it, you're seeing hydroxyzine, you're seeing even Seroquel, quetiapine, then you can have a kind of an idea that patient has perhaps some issues, because those are all potentiators, and they increase the high, they increase the intensity. They also are used, the gabapentin and the benzos, very, very unsafe, dangerous, risky behavior to utilize that with fentanyl and the opiates, but it's done, and that is a big reason why we're seeing an increase in overdoses because of the combination here. But they use that so that they can use less of the opioids or the other substance. So it potentiates, so they can get by, if they've only got, say, $50 to spend on their drug of choice, they may utilize some of these other substances to help that go further. Alcohol's huge in that. So the Seroquel is a sedative, and so at high doses, again, that's a potentiator. And I didn't put it on here, but I probably should, is bupropion. So that's called the poor man's cocaine, and it can be misused. It's also very, very positive, and so I sometimes hate to mention that because I don't want you to not try that in some of these cases or not put patients on that, because it can be helpful. It can help urges and cravings of the stimulants, including the methamphetamine. Have had some success with that. Off-label use of methamphetamine and for methamphetamine is bupropion and Vivitrol. So those two together can be helpful. Cocktails. So that's when combination polysubstance. You just kind of putting everything in there. You can Google cocktails, and I did this. I don't know, quite a few years ago, and it's really interesting. Gabapentin, 800 milligrams, for example. People will say, "Oh yeah, put 10 in there. Put 8 Flexerils. Put It's just amazing what some folks their tolerance level is. So it's good to be aware of that cocktail. One of the things on the street now is Trank, and that's fentanyl and xylazine, which is one of those new kids on the block that we're going to touch on. Holy Trinity, which is an opioid, a benzo, and a muscle relaxant, typically probably cyclobenzaprine, or Soma, which is the only controlled substance of the muscle relaxants. The B52, you can read there how haloperidol and lorazepam, diphenhydramine, Benadryl to prevent extrapyramidal symptoms. You might want to throw that in there. So that's kind of an interesting combination. And then there's the pink cocaine, which is pink food coloring, flavoring, and ketamine along with caffeine, and then MDMA, also known as ecstasy. So let's look at the new kids on the block here. Xylazine, very, very dangerous. It's actually a veterinary medicine, and that's how we think patients are getting it off that market. It's not being produced necessarily. It's colorless. It can be in liquid or powder. It's converted to a bitter tasting salt solid, and then it can be mixed with other substances. So one of the things that we're seeing is inadvertent use with it because it's being laced into the supply of the fentanyl, and so inadvertent use. It's added to as a filler again, so that the profit margin is higher for those traffickers and the drug dealers. Very, very dangerous. The pharmacology, I'm not going to go over much of this, but it's basically an alpha-2 adrenergic agonist. So at different levels of it, it acts differently. So it mimics many different drugs. It can be very difficult if you're seeing a patient in the ER or this sort of thing that has a bunch of things going on to kind of pinpoint that that's what's going on. But it's certainly something to think about, particularly if they're having some skin issues as well, because it is known for its ischemic ulcers at the site of the injection because of the vasoconstriction effects of it. So if you're working with that population, you're in the ER and you see that, then certainly you're going to be thinking xylazine and ask that patient. They may not know that it was in there, but but if they've used fentanyl and you're seeing that, then that could be a chance. Alrighty, so xylazine, there's some complications here. I'm not going to go into that, but Narcan is not a reversal agent for this. We really don't have a reversal agent, which is one of the big downs of this. However, because it is associated quite oftentimes with opioids and fentanyl use, you would Narcan them. You'd Narcan the heck out of them. We had a patient, now I don't know that they had xylazine, but just an FYI, we had a patient that was in our office that was brought by another person out in the parking lot, and that person who was with the person in the car came running in the office and said, "Help me, help me." The staff went out there, and the person had overdosed. They were blue. They didn't have a pulse. It took 6 Narcans to get that person back. So that's what we're seeing with the fentanyl and possibly the xylazine on board as well. There's a skin ulcer induced, which is quite quite ugly looking and difficult to treat, difficult to heal. So the second new kid on the block, Zaza, the gas station drug, it's tianeptine, and it's a tricyclic antidepressant. It's at high doses reduces anxiety, can cause euphoria, can give relaxation, and it does bind to the mu receptor, which is the same as other opiates. So you can see some withdrawal, and we've actually had a patient in our clinic who came in for Zaza abuse, and we ended up putting that patient on buprenorphine and treating them as an opioid use disorder, and it was successful. So this you can buy right at the gas station. It is softly maybe reversed by Narcan, but not consistently. So again, if a patient has overdose, we're going to Narcan, and we're going to Narcan the heck out of them. MAT, so barriers, treatment, goals. I know we're kind of running short on time here, so I'm going to start talking a little bit quicker. Personal bias. I had a personal bias for years until 2016. I wasn't going to treat this population. I didn't have a judgment. I didn't pass judgment. I had somebody in my practice who was treating them, and they said, "You'll love this population. Treat them. You know, they're the best. They're the most grateful and fun to work with." And I was like, no. But wow, did I do a turnabout when I met this population and the needs there. So certainly personal bias, but it can change. Clinical support staff issues, the stereotype, I don't want to be around that. Concern about their safety. We don't see that a lot. Certainly where in any situation in healthcare, anywhere, we have to be on guard, but we don't see that anymore, I don't think, than any other place. Stigma, you're just replacing one drug with another. Well, you can argue that. Certainly we're giving a medication that's well tolerated, that's very, very safe. The buprenorphine product is very, very safe, as opposed to being on fentanyl and overdosing. Very difficult to overdose with buprenorphine, Suboxone. Very difficult. Yes, it can be done. You can overdose with Tylenol, but it's very difficult if you're taking it appropriately. And it actually can provide some protection because it binds to those mu receptors tighter than any of the other opiates, the fentanyl, heroin, and methadone, for example. It binds to them tighter, so it provides some protection if that person does use, and it will block the euphoria some. Provider requirements, much less than it used to be because we're not required to get that X waiver. Lack of education, mostly experience as well. So lack of education and experience creates angst, nervousness, and with all the regulations, you worry. So we have lack of providers. It's certainly a barrier. The treatment, we have medications. We have those that are FDA approved, and we have some off-label choices. We have the ancillary services, very important in MAT. Individual counseling, IOP, group counseling, your 12-step programs, targeted case management. Those are staff members that really help with community resources to align that person with what they need. Not one size fits all. So you've got to help that person find what they need. Peer support, very, very important, very effective. And in order to be a peer support, you have to be sober for 1 year. You go through some training, and then you get your certificate. They actually get paid to do that. So I highly recommend that to some of my patients, to have a goal to be that. Community resources, criminal justice involvement, for sure. We need more of that. We don't have enough of that. And then we just need to give support to this group. We need to provide that in many different ways. Here's a tool if you're concerned about how do you diagnose opioid use disorder or any of the other use disorders. You just utilize this tool. It's called the DSM-5 criteria for opioid use, the DSM-5 criteria for anything. You just substitute opioid for alcohol, for methamphetamine, for spice, for whatever. It's the same 10 questions with one of them having 2 parts. So there's a total of 11 answers. Typically, most of our patients that we see are severe. They answer positive to 6 to 11 of those questions, and 2 to 3, so that's not hard to reach, is mild, and 4 to 5 is moderate. So most of ours, again, are severe. In order to be in a methadone clinic, you have to reach that moderate to severe level, and again, that's not that difficult to do in this population. Medications, we have the methadone. That's very regulated. You have to get that in a methadone clinic. NTP, narcotic treatment program, that's what it's called in Kentucky. Other states call it OTP, opioid treatment programs, but Kentucky has to be, our own. So we say NTP's buprenorphine monoproduct. Brand name that we most hear is Subutex, the buprenorphine naloxone combo product. Mostly we hear the Suboxone or Zubsolv, for example. The combo product was put together to help prevent diversion, because if it is utilized IV, it will decrease the euphoria effects and maybe create some induced withdrawal. It's probably more associated with that buprenorphine product blocking the mood receptors. And then we have the naloxone, which is the Narcan, and then the naltrexone, which is your Vivitrol long-acting or the oral form, and then the off-label medications that we're not going to get into. I like to mention the comfort meds. It's very important. This group does, if they're going through withdrawal, they can benefit from clonidine big time. It helps with the anxiety, sleep, some of those symptoms of sweating and heart racing, those kinds of things. Lucemira, the brand name, the generic is lofexidine, is very, very helpful. It's very expensive. However, Medicaid in Kentucky has to pay for that. Some of the pharmacies do not stock it, but it's very, very useful. I think of it as clonidine on steroids. It also can help with the nausea and some of the other withdrawals. Dicyclomine, if your patient says, yeah, a lot of my withdrawal symptoms are GI related, you might want to think about that. Anti-nausea medicines for sure. This is one time when I will use promethazine. Promethazine is considered a potentiator, so I will not use promethazine later as they're in recovery, but I will use it during the induction phase to help them sleep through it. Analgesics and then sleep aids like trazodone, maybe something along those lines. Here's your options for Narcan, the 4 milligrams, Clexato, which is the 8 milligram, double the dose, and then the new Zimhigh, which is the auto injector. It can go straight into the thigh through the pants there, and that's 5 milligrams. So the goals: prevent withdrawal and allow time for other activities, kind of get back to life. That's the goals of MAT, of treating these substance use disorders. We want to reduce unsafe needle practices, reduce those infectious diseases, reduce that 1 in 20 Hep C transmission, and overall improve health, overall improve the quality of that patient, eliminate the need to get illegal drugs, which has a huge positive side to that for sure. Reduce neglect and abuse, get those patients back to where they can do their family responsibilities, their work responsibilities, actually be gainfully employed and a very meaningful member in the community. Certainly the emotional availability is very, very important. So with MAT, particularly when we're treating opioid use disorder and with a buprenorphine product, 2 things that we want to see. Number 1 is the withdrawal symptoms go away. We treat that. We can do a very, very good job of that with the buprenorphine products. The state of Kentucky, we can go up to 24 milligrams. And a lot of times with fentanyl now, we do have to go above the norm, which is considered 16 probably in the past. We do have to go up higher, and don't be afraid to do that if need be, but we may need to go up to that 24 milligram max. Some states are 32 milligrams, we're 24. The second thing I want to see out of that treatment for the MAT for opioid use disorder with the buprenorphine is to make those urges and cravings tolerable, if not gone. Sometimes we can't take them away, but we can make them tolerable. Why can't we take them away? Because it's not related to necessarily the withdrawal or the medication. It's related to other things that need help. For example, relationships, stress, financial issues, all those things that the case managers can help with, or our mental health providers. So we have to look at all that to get that person treated, but we expect those 2 things out of the medication. So if a person tells me maybe I'm not sleeping well, or they're telling me I don't have enough energy, those are not 2 things that I'm going to increase that medication for. We're going to look at other things that are going on in order to get those symptoms abated. Regulations and compliance, we hate those words, but I have this here because I think it's helpful. Statutes, regulations, what are all they? The ordinances, the local law, scope of practice. What does that mean? The guidelines, the best evidence available that we use, the standards of care, again, what's reasonable and prudent, and can you defend yourself in a jury of your peers? It's what I tell my providers when they're going off protocol or they're going outside the policy or they're doing an off-label. Can you, in front of your peers, can you justify what you did? Can you rationalize it? Can you give support on why you did what you did, and document it, by the way? So big on that. Practice policies, they can be stricter, but they can't supersede, they can't go over the law for sure. So here's some federal regulations for MAT. I've got a link there. Title 42 CFR, Public Health. Part 2, very, very important. That deals with the confidentiality and the ROI is specific to that. So that's very important. The Data 2000 Act, and then the Comprehensive Addiction and Recovery Act of 2010, CARA, the Support Act. I'm not going to go into those in particular, but there they are if you want to read about them. So the Kentucky state regulations for MAT, physicians and PAs, you've got your link there. APR statutes. Interestingly, the APR regs and MD regs are different. So you may know, if in my case, I know my regs, but I have 20 plus APRNs practicing under me. I have to know their regs, and they are a little bit different. Not a lot, but some, and so we have to be aware of that. The PA statutes, they're still, the PA is under our licensure, so the KBML, and our regs are also their regs as well, but there's some information there. MAT in Kentucky, we no longer need our X waiver, thank goodness. We no longer have patient limits, very positive. We can write it. If you have a DEA, you can write buprenorphine product. You need to understand the regulations and provide standard of care, but it's not that difficult, and we can certainly help you get that done. If you've never had the X waiver with the new training requirement that went in, I believe that was June when that went into effect, you have to have 8 hours of an approved substance use disorder training to get that done. There's plenty of those even free out there to get that done, but that is necessary for anyone with a DEA, not just prescribing buprenorphine products. So any DEA eligible provider can prescribe buprenorphine. And where do we see that? Ideally we see it in the primary care offices. We see it in addiction clinics. We see it in ERs. We're going to talk about that, and other integrated systems. So perioperative management on buprenorphine, I just like to mention that in the past, it was you got to get off of it for 72 hours. We don't want you on it. It's going to block this. It's going to do that. No. Right now, we want you to stay on your buprenorphine products. And yes, you can provide 3 to 5 days of a prescription opiate for breakthrough pain. They might require a little bit more, but that buprenorphine is going to give some pain control. Now, in the addiction world, we have them take it all in the morning because we don't want them chasing that drug all day, thinking about that constantly. We're trying to rewire that brain. However, a caveat to that is the buprenorphine product will work better for pain if you divide that up. So if you have a patient who's going to be having surgery and they're on, say, 24 milligrams, which is 8/2 tablets or films, you might advise them during this time to do 1-3 times a day, for example. But ideally, we don't want them to go off of that product. Now, if they're having a severe shoulder replacement, we all know how painful that is. Yes, that might be a situation where you might want to talk to the addictionologist and come up with a different plan. Maybe that person does go off their buprenorphine product, but having a plan of action and the patient and you and everyone's involved will increase the likelihood that they will return back to their previous recovery path after this recovery period is over regarding their surgery. But typically, most of the time, we don't have you stop the buprenorphine product. You just continue it. Oftentimes, UK did a study that looked at prescription opiates versus Tylenol and ibuprofen, and there was no benefit to using the prescription opiates in the surgeries that they looked at, the outpatient surgery. So very positive finding there. And so we don't always have to have prescription opiates when we have surgery. Dental surgery is a big one. Ibuprofen works great if that person can take the NSAID products. Alrighty. MAT integration, we're going to increase access to MAT. Again, remember, that's one of those barriers. We're going to reduce stigmatism. So if they're incorporated into your practice and your primary care, there's no stigmatism associated with that. They don't have to worry about walking in that door, so to speak. We're going to provide empathetic, compassionate care. You're the best to do that for sure, the primary care folks. Any medical provider can provide empathetic, compassionate care with respect and dignity. That's all these patients want. Many of them have never had it. We're going to look at a multidisciplinary approach when we're doing that as well. So again, we went through that. The justice, criminal system's big part of that. If we could get our resources in those buildings and help those folks, an inmate coming out that used drugs going in has up to a 40-time increased risk in the first 2 to 4 weeks of overdose. Why is that? Because they come out, they think they can do the same tolerance level, the same dose before they went in, and their tolerance to opioids has gone. So they use the same amount, they overdose, they die. So not a good plan there. There's many programs now where inmates, when they get out, being released, are trained on that, and they're actually provided Narcan. So that's a very positive, but we need to have more influence in that world. Emergency departments. Do I have any emergency docs here there? Okay. So hopefully you'll be watching this. I hope at some point. But there's great information that initiating the buprenorphine, even after providing Narcan, is a positive factor in putting that patient in a recovery mode. Does it work all the time? No. Does anything work all the time? No. But it gives that patient a pathway. The Bridge, under the direction of Dr. Andrew Herring out in California, they've done a lot of work on this. They've done most of the work. There's 2 links there that are going to show up as well here, and it talks about the benefits of that. And not only that, but they go on to look at actually a protocol on how to do the induction in the emergency room at that time. And then we see, again, we're providing that empathetic, compassionate care. We're seeing the time of need. What bigger time of need than right there after they've overdosed or have come in for some kind of complication from utilizing drugs intravenously or otherwise. So right then, access to care at the time of need, we can initiate that buprenorphine and utilizing that multidisciplinary approach and a warm handoff. So get your resources in your community and have that available. There's resources in the West Winchester area of a peer group that comes in, and they actually come in at the time of the overdose and deliver that person the next day to an addiction facility. It's very incredible, very moving when you hear these 2 gals who started this program talk. It is quite incredible, and for some of us, it'll bring tears to our eyes when we listen to their stories. So very moving. But that warm handoff is incredibly important. So the why. So what are we doing? So we talked about this. So that's a bag. It looks like heroin. It could be fentanyl. It could be heroin laced with fentanyl. It could be heroin laced with carfentanil. It could be fentanyl with carfentanil. You name it, xylazine in there. We don't know what's in there. Nobody knows what's in there. I'm even seeing benzodiazepines. I'm seeing MDMA. I'm seeing methamphetamine in THC, in marijuana. So we're seeing all kinds of stuff in this when we get the urine toxicology confirmations back. We'll let the patients know, we saw this in your screen, and they'll be like, you can't be there because I didn't use that. And you'll learn that you can trust these patients. You'll learn. I mean, they have nothing to not tell us because we're seeing it. There's no secondary gain to tell us that they're not using. So we feel like that's accurate information for sure, and we're seeing that. So you got your paraphernalia there. You've got your They're heating it up, getting ready to inject it. That fluid could be saliva, it could be water, it could be fluid water from the commode. I've been told that before. Drawing it up. This could be your brother, your sibling, somebody else's cousin, whatever, your classmate, your colleague. And the point of this is to know that this crosses all socioeconomic levels, and then this is what we're really looking for to prevent. So that is one huge goal. I love showing this. I've got this patient's permission. The top there is her mugshot, and that bottom is after she was in recovery and got her life back. So the because, the why, you see it. Improving the quality of the life of a person who's addicted to drugs improves the life for everyone. And we're all touched by this disease, substance use disorders. Even if you've never touched an illicit substance, you're touched by it in some fashion, whether it be a personal family member or a job colleague or someone else in the community that causes some grief there. So in summary, addiction is treatable. It's a chronic medical disease, no different than asthma, no different than high blood pressure, no different than diabetes. You're not going to kick someone out just because they ate a donut and they're on insulin. You're not going to kick them out. We're not going to kick these folks out just because they had a relapse. We're going to wrap our arms around them and we're going to bring them back and we're going to get them right back on that path, just like we do for that diabetic or the person who's gained 10 pounds and is on blood pressure medications, you name it. But you're empowered. You can do this. It's not that hard. It really isn't rocket science. And there's an incredible amount of reward associated with treating this population, getting to know this population. It's incredible just what a little pat on their back can do. I've been so many times just overwhelmed by when I show some empathy and respect and dignity to a patient. They'll go, I've never been told that. No one has ever told me I did a good job. Wow. It's just incredible. So, all right, there's some references there. I think we did it. I went a little bit, well, I probably didn't go over because we started a little bit late. So yeah. But do we have any questions at all? Yeah. Yes, Dr.
Buprenorphine treated so special, and we could already prescribe it for pain, and it seems safer than a lot of other opioids. And the data really supports maintenance therapy over detoxing and sending them home.
Yes. Yeah.
So it doesn't make any sense.
Yeah. Yeah. I've got a good answer for that. I have to repeat the question. So the question is, why is buprenorphine so different, treated so differently? Why is it regulated like it is? Because the people who are regulating it are not out on the front lines treating this population, right? It's for years, this population has been, the treatment quite oftentimes has been punitive. It's criminalized. It's not a supportive, culture. Now we're seeing that change, particularly methadone. If you think about that now, the buprenorphine product is very, very safe. As Dr. House mentioned, it has a ceiling effect. So the buprenorphine, as you go up in dose, it levels out. So no matter how much more you take, you don't get any more euphoria, you don't get any more effects, you don't get respiratory depression, that sort of thing. Now again, can you overdose with buprenorphine? Yes, you can. You can overdose with Tylenol, but it's very, very safe. It also, because it's a partial agonist, when it binds to that mu receptor and it binds very tightly, it's protective. So it protects that patient if they go out and they use heroin or fentanyl or that sort of thing. Now, can you override that protection? Sure. You can take enough and drop off on the other side, but it's considered protective. Now, methadone, the more you take, the higher you go, and you get to that risk of respiratory depression. But we're seeing with the COVID era, and in methadone, you may or may not know this, but the patients have to come dose daily. I know you know that, but how long does it take to earn a take home in the system, in the previous system, and in the current system, which I'll explain. So when they start, they come in, and in the state of Kentucky, up until January, they had to dose every day for 90 days. we were not closed. We had to be open in the state of Kentucky in a methadone clinic. So starting January, those regs did change. We can close on Sunday. So now they automatically get one take home. So they come in for 90 days, 6 days a week, and they get one take home. At the end of that 90 days, if all have gone well, they're in positive recovery, their urine confirmations are good, and that sort of thing, then they get two take homes the next 90 days. Repeat that scenario. After 180 days, if all's well, they get three take homes. Repeat that scenario. After an additional 90 days, they get 6 take homes. So they're coming once a week. It takes 2 years in the current system to get 28, actually it's 27 take home days. So 2 years coming into that clinic before they get the chain cut. Now, during the COVID, which I was involved in a very busy methadone clinic during that time, during that era, we had to still be on site. We were considered essential, as many of you were, probably all of you. So we had to be on site, and those patients still had to come. However, with the PHE, the Public Health Emergency, SAMHSA issued an emergency order that was supported by the governor, and we were allowed to do these flexible take-homes. So patients immediately got take-homes. Now, not the new patients. We didn't give those because that would be unsafe. But if we felt like the patient was safe, we could immediately, quickly give them take-homes up to, even in some cases, up to 27 days, even though they hadn't been there for those 2 years. So when the PHE ended and was ending, SAMHSA really looked at that, really looked at data that was associated with that, and found that there was no increase in diversion, there was no increase in overdoses, there was actually retention and recovery centers. And so now, just recently, we have the option of adopting that flexible, it's called the SAMHSA flexible take-home, and we can utilize that at our discretion as the medical director of an NTP in the state of Kentucky. We have to rationalize it and show it, but yes, we can still do that. So things are changing. That was a long answer to your question, but it's regulations. It's that fear of keeping a tight hold on something. What's interesting is methadone can be prescribed by a pain management, by family medicine, by internal medicine for pain, but you can only prescribe methadone for substance use in a very regulated clinic. Same issue that you mentioned. But this population is high risk. There certainly do need to be some boundaries. There need to be some regulations. There need to be some policies and protocols. Do they need to be as regulated as what they are? Because that creates an obstacle, because folks don't want to go learn it. They don't want to do it. They're afraid. So we don't do it, right? But again, a long answer to your question. So I appreciate that. Anything else? Yes, you have something?
Let me give you the question, maybe I can give you the spin after the question. Do you in your position see that all opioid addicted patients will be permanently addicted? And that's the question. Let me give you the spin. In my limited work in this area over the last 10 years or so, I understand that a group of people, the functional or clinical part was they went to Vietnam, they became heroin addicts, they came home, the world was over, they were depressed. There's just a great majority of people that just went back to their lives. There was a small minority that continued to use the substance because they couldn't get off. My query is, what I think the query of a lot of clinicians is, well, what's the number? So is the number half of all patients, will they come off one day? Will 10% come off? Will none of them come off? Will 5%? Will 80% come off? And what we're querying is, I don't see any data, and I don't see anybody working on data to tell us that a good pain management clinic with lots of volume will see about this number. And that's what I don't understand is, do they just go, all these patients go from an opioid, they can go to Suboxone, they never come off. And for us to believe that they're going to come off is some type of misunderstanding, or we don't understand. I just don't know I don't see any clinical studies that support, well, 100. I know the people that make the drug want 100% of the people on it all the time. The same people I think that make the drug now used to make the other drug. See, that's why they made the deal. They made the deal over here to get people here. They've got all the restrictions off. There's no restrictions cap on anything now. So now they got as many people as they can using it. I want to understand who's going to come on. What's the number?
Yeah. Yeah.
And why do we not? If we don't know the number, why do we not know the number? I mean, it's been how many years we've been doing this now, and who's going to do the study that says this is the rational number based on the information that we have today, with the best science that we have today, with the best addictionologists? What's the number?
Yeah. Yeah. Great question. So to repeat the question, once a person has that diagnosis or that condition of addiction, particularly opioid use disorder, is it permanent? Can they, if they're in a recovery program, taking a product such as the buprenorphine combo product or mono product, Suboxone or Subutex, can they come off of that? So what's the number? What's the number in recovery? What's the number that comes off? How does that work? Well, to answer your question, there's so many answers to that. Number one, yes, they can come off. Yes, I have had successful patients want to wean off. Now, the studies show that we don't even approach that until they've been successful in recovery for at least a year. It used to be 6 months, then it went to 9 months, and now it's a year. It's the longest that that person wants to go. So when I talk to that patient, I say, we're a partner in this. I'm going to continue to talk about this because there's been plenty of patients that I've met that they were like, I didn't even know that tapering was an option. Nobody had mentioned it, in particularly methadone patients. We had a patient come from Florida that was on over 300 milligrams of methadone. And, we got that patient. We're like, wow. And she's like, yeah, I'm like, has anybody ever talked to you that maybe you don't need that much? And she's like, no, they just kept giving it to me. You mean I can wean off of that and get down? And I, absolutely. And she was positive about it. So she wasn't not telling the truth, right? I mean, because she just had never been told. So having that conversation. So the answer is yes, but we don't approach that until at least a year. Now, we have patients earlier that come in and they say, I don't want to be on this. I want to get off. I want to get on. I want to get stable, and I want to get off as quick as I can. We don't want that because we know the studies show, and there's very good studies about that show that the relapse rate is much, much higher if that person is weaned down prior to that 12-month mark. Do patients continue on it for life? Yeah. There's some patients that never get off. They don't want to get off of it. They're for whatever reason. It's just like a diabetic doesn't want to do the lifestyle changes, which many of us could, in order to stay off that insulin or stay off that metformin or stay off, right? It's too hard to do the things that we need to do to stay off of that medicine. And they're making that choice not to. So there are those. The reasons why we don't have good studies on the number and so many things, it is so difficult when you're doing any study for a long amount of time to keep track of this population. Just follow up and keeping track of it is so difficult to manage that. So you're right. The studies, that's a great question. How many of these patients are going to be able, if I'm treating 100, can I expect 80% to come off? No, in my dealing with it, I would say it's more like 10%, 20%. That's just my experience. That's not backed up with any evidence-based. But I will look into that. Dr. Corey Waller is I don't know if he's our CMO. He's been with us about 8 months. He's incredibly knowledgeable about this. He loves evidence-based medicine. If he doesn't have an answer for that or nowhere to go, there is no answer. So I will get back with you on that. I will pose this question to him and see if he's got a good answer. But yeah, it certainly is an option both ways.